neurology examinations can be difficult sometimes because the signs may be not correct or the signs may be difficult to elicit, making the interpretation of the signs a bit difficult. There is upper motor neuron and lower motor neuron in our limbs examinations, mainly in the upper and lower limbs examinations. And in neurology, beside this, we have other things like cranial nerve, we have gaits, we have speech. But today I'll cover mostly the limb examinations, and then we'll go through some of the basics, and then we'll see whether you can come to a conclusion or diagnosis. In the limbs examinations, we divide the findings into upper and lower motor neuron based on anatomy. And remember, upper motor neuron start from cortex. So there are 6 levels of upper motor neuron. One is cortex. The second is corona radiata, internal capsule, brainstem, spinal cord, and anterior horn cell. So there are total 6 levels in the upper motor neuron. And then there are also 6 levels in the lower motor neuron. So we start from anterior horn cell. So lesion in anterior horn cell can have mixture of upper and lower motor neuron features. Then what happened in the next level is the roots, then the plexus, the nerve, the neuromuscular junction, and the muscles. And the nerve, we usually divide them broadly into polyneuropathy, which many nerves are involved, or mononeuropathy, which means only 1 or 2 nerves or a few nerves are involved. So in these conditions, you will see that we are able to divide the lesion into unilateral and bilateral. So think about it, which are unilateral, which are bilateral. So what we can see is that cortex lesion, corona radiata, internal capsules, brainstem, these are usually unilateral. So brainstem, occasionally it can be bilateral if the lesions are big or if it's in the basilar artery, but mostly unilateral, like Picard syndrome or lateral pons syndrome, then they are unilateral. Whereas spinal cord and anterior horn cells, especially spinal cord, most often in the exam, we get bilateral spinal cord lesion. But occasionally you got brown sequoias, but not common now. Most often they are bilateral. Whereas for roots and plexus, they are unilateral. When for nerve, if it's polyneuropathy, neuromuscular junction, and muscle, then they are bilateral. Okay, so from here you can understand that what happened to the arrangement or organization of pyramidal system is that certain part are control of one side, certain part are control of both limbs at the same time. So from here, we form our basis of understanding what are the likely lesions or what are the likely anatomical diagnosis in the lesions that we are looking for. And beside this, another things we usually look for is it more proximal or distal? So for anterior horn cell, the lesions are usually more distal. These are more distal. What other lesions which are more distal are usually nerve, like polyneuropathy, they are more distal as well. But sometimes it can be more proximal. For example, in CIDP Guillain-Barré, it can be more proximal. Whereas for muscle and neuromuscular junctions, they are usually proximal. So technically, this is a philosophical question now. Do you know why why myasthenia muscle disease, they are more proximal? Can anyone answer this philosophical question?
Bigger muscle bulk.
Yeah, huh? So in the neuromuscular junction lesion like myasthenia or muscle disease, the bigger the muscles, the more prominent is the symptom. So it doesn't mean that the distal muscles are normal. In fact, they are also abnormal, but because they are smaller muscles, the patients doesn't feel the weakness that much, and therefore they doesn't complain. And when we examine them, it's not that obvious. Whereas why the motor neuron disease and polyneuropathy, they are more distal is because they are length dependent, or they involve or affect the smaller muscles more. That's why the distals are weaker. Okay, so for example, in the motor neuron disease, the wasting, although they are both proximal and distal, but is more prominent in the distal region